everyone. Welcome to our first BurnCast of 2024. My name is Joanna Kim. We are joined by Anne and Liz, who are part of our burn team. And today we have a special guest, Dr. Isby from our emergency room. Dr. Isby, did you just want to introduce yourself
Sure.
a little
Thanks for
bit?
having me, guys. I've been working with Liz and Anne on improving our discharge for burn patients in the emergency department, and I'm really excited to be here today to talk a little bit with you all about taking care of burns and how to provide great care for our burn patients in the ED.
Wonderful. Thank you so much, and welcome to our BurnCast. So today we're going to be talking about, like Dr. B has talked about, alluded to, our burn debridement process in the emergency room. A lot of our burn patients are seen in the emergency room and gets discharged home to be followed up in our clinic. And in that process, they get debrided and dressed in the ER. So we just wanted to talk about that process. Of debridement as well as the discharge to follow up in the clinic. And so I guess a good place to start at the beginning is a little bit about burn assessment. Liz, if you can just let us talk about the different degrees and characteristics that we'll see in the ER.
Yeah, absolutely. So burns used to be referred to as first, second, third degree, and now we're more specific about the types of burns. So first degree burns we now call superficial burns. Superficial burns are like a sunburn. So you'll see pink skin, you'll see really no blistering, but really it's just that top layer that's involved in the injury. Most of what we see though are what we used to refer to as second degree burns. We now call those partial thickness burns, and they're divided into two categories: superficial partial thickness and deep partial thickness. And we can talk a little bit more later about kind of what characterizes each of those. And then third degree burns, we now call full thickness injury. They involve all of the dermis, and they're the deepest type of injury that we see.
Thank you. And how do we calculate the TBSA? Like a quick way to do it, and then in the emergency room, and so that we can get an accurate measure of how much has been affected. Anne?
Yeah, so the quickest or easiest kind of way to eyeball what the total body surface area of a burn injury is to take the patient's palm and fingers. So it's their entire palm and all 5 fingers of the patient, not yourself, because it can be very different in pediatrics, and estimate one total body surface area is 1% is the patient's palm and fingers. So you can use that to get kind of like a quick down and dirty reference of a good quick estimate. If you want to be more specific about it, there's an app that you can get on a smart device called Easy TBSA, and you actually put in the patient's weight, their age, and then you mark on a diagram exactly where the burn injury is, and it will give you a very accurate and more specific total body surface area, or TBSA, for that patient. So I often like to first estimate myself. Sometimes I will, like if the burn's on the chest, I'll actually take the patient's hand or arm and put it over their chest, and I say, oh look, there's 1, and I could almost do, almost map it out with their hand as almost like a stamp. And then I'll check myself in the app and see how close I come, and kind of if I think maybe I drew it wrong in a little spot, or I need to kind of edit what I've done there. And that's really the best way to go about getting a TBSA. It can take a little bit of time to sit down, calculate everything in the app. So when a patient first comes in, to really get like a good idea, especially when you're triaging them into where they need to be in the emergency department, it's best to kind of use your quick estimate with their hand.
Do you find that you get your TBSA changes like pre and post debridement?
I think that's provider specific. I think I'm often surprised by what debrides when I thought it wasn't going to debride. I think it also depends on how how impressed you are by the burn. So maybe you overestimate. Sometimes I underestimate. We're also cautious in burn injuries if they go into the scalp or something like that, where you think that maybe it stops at the hairline. You can get like a whole, 9% from just being in the scalp. So there's a lot of places where you can think that it maybe just a little spot has blistered. And then I keep popping in and out here. I'm gonna have to change my virtual background. It's distracting me. Hold on one second. But I actually think that a lot of times you can get very surprised by the fact that you think the burn is 2% and it ends up being 7, or you can think that it's 10 and it ends up being 4, and it happens to everybody.
And do we like, so it's I'm sure like to upload onto the chart so that we have an idea of what the burn looked like pre and post. We take pictures of it and post that to our charts. And I guess I just answered my own question.
I generally we're mostly looking for post-debridement photos. So we're
Okay.
happy to have pre-debridement photos as well. But if you're only going to do one or the other, I'm here for the post-debridement photos. Because just for the reasons that I said, like if you're going to try and debride a burn, sometimes an area you think is going to debride either does or doesn't. So post-debridement, and then we can also get a really good look at the wound bed. Because if you have that denuded skin kind of left intact on top, it's hard to visualize the wound bed. So post-debridement photos are always my favorite photos to be able to take a look at.
Awesome. And
Dr. Isby, how do you, oh,
yeah.
sorry, I'm interrupting. I was gonna say, how do you all capture your photos in the emergency department?
So we usually use the phone, the Zebra camera capture. So use the Zebra phone and use the camera capture app. Some of us, I have it on my cell phone as well. You just have to make sure you're explaining to family exactly what's happening and that they're going into the computer system, not being saved either on your cell phone or on the Zebra phone anywhere. And then for the post-debridement photos, I find this especially in the younger kids can be a little distressing for the family because you just debrided and the kid is screaming and you're, it's going to feel a little bit better, at least once you put that Meplex or whatever over the top. So just really having a clear conversation with the family about what to expect before you start, including that you're going to pause to take a picture to help with the follow-up care is really critical so that the family doesn't wonder kind of why you aren't finishing up as their kid is crying.
Yeah, that's it's such a distressing situation, and especially they come in traumatized from the actual burn, and then to go through the whole debridement process,
Exactly.
and can you just speak of the debridement process that you guys do in the emergency room? What kind of burns do you guys actually find that you debride more of?
So most of the superficial burns, like Liz was talking about, don't have blistering, and so they don't need debridement. So it's really just supportive care. The majority of the burns that we see are these partial thickness burns that Liz was discussing and will need debridement. We do see some full thickness burns, but oftentimes we are consulting and having the surgery team help us with those. And then there are other specific burn types that we consult the surgery team for regularly, such as genital burns or crossing palmar creases, other things that we're concerned about and want their expertise at that time with instead of waiting till the burn clinic follow-up.
And who tends to do the debridement in the emergency room?
It varies. So if we consult the surgery team, they are involved in the debridement since they've been consulted and we appreciate their expertise. Oftentimes it's a provider such as myself with either a resident or a PA that's doing the debridement. And then of course we have other support, especially for our younger patients in the room to help hold them and keep them in position so that we can do it quickly and successfully.
And Anne, can you talk about like the type of materials that you would need to gather so that we are more prepared to actually do the debridement in a more smoother way so we can have everything in the room available?
Yeah, so generally when I'm performing a burn debridement, I try and get everything ready. And, Dr. Isby mentioned preparing the family. I think that's really critical spot or thing to do. I think that's really important. Especially saying I'm going to peel off the dead skin because it's very visually alarming and traumatic to see the kind of dead skin being wiped away or pulled away if it's like a thicker palm burn. So I try and always tell the patients and their families about that. So getting them all prepared is really important. And then I generally use gauze and wound cleanser or soap and water, depending on if the burn's really kind of older and really crusty. Sometimes I'll soak it in a soap and water solution. But if it's a fresher burn and it's kind of moist, it's easier to use a wound cleanser and soap and water. Or I'm sorry, wound cleanser and a gauze, and then whatever bandage you're going to use, you want to have that prepared. I also have my wraps, my cling or Curlex prepared. I get my tape ready, and I actually cut off a piece of tape so that I have it like ready to go. So you can just pull a piece. You don't have to stop to unroll tape. If it's on the chest or torso, upper extremities, a burn shirt or some sort of sleeve. On the lower extremities, sometimes I use an ACE wrap. So really trying to think. Sometimes what I do is I think through the process of debridement and I think, what are all the things that I need? So I'm like, okay, first I'm going to take a gauze and wipe it. And then I'm going to so then you can actually remember through each step of the supplies that you're going to use. Occasionally I use adhesive remover if somebody's put a piece of tape and a bandage on a burn. But those are generally the items that are used for a burn debridement.
And how much pressure is actually needed to take off the dead skin to so that we're not, again, causing more trauma and more pain, I guess, when we are doing that process? Can you talk about that, Liz?
Yeah, absolutely. So instead of a scrubbing motion back and forth, firm pressure with a 1, 2, 3, good wipe, oftentimes will get most of that denuded, that blistered skin off. You may have to repeat it, but again, we want to avoid kind of a scrubbing type of motion. There's also another type of burn, contact burns to the palms or the soles of the feet. That skin's a bit tougher. So we may have to employ a technique like popping the blister with a suture removal kit to really release some of that fluid in an effort to either trim that blister a little further or further wipe it off. So, but in general, just, a firm pressure, I'll say that.
Awesome. And Dr. Isby, can you talk about like the pain medication, like how you come about deciding who needs to be sedated and what kind of pain medication is used on particular patients?
Yeah, so usually patients that have it really depends on the location of the burn, I guess I should start with. Any burn in a very sensitive area, so any genital burn, we would be talking to surgery and then doing sedation for cleansing and debridement. It really depends some on the patient and their age. Most of the burns that are less than 5%, we can use intranasal medication, so intranasal fentanyl for pain control, and do the debridement and send patients home. Depending on the extent, or if it involves, the face is another area that's very sensitive and very hard for patients to sit still. And then intranasal fentanyl can cause some nasal irritation. So if you're trying to clean and the patient's wiping at their nose, it can make it hard. So it really, kind of depends on where the burn is located, but certainly, an extensive face burn that needs debridement, genital burn that needs debridement, or, if a patient is really not tolerating the procedure after the intranasal fentanyl, we would switch to a sedation for the debridement piece.
Thank you. And then like you guys alluded to, what goes hand in hand with the debridement is the dressing. So, Anne, can you like talk us through, is there like does everybody get the same kind of dressing, or how do you guys pick the initial dressing that you guys use for those patients?
Yeah, good question. Generally, our goal, if possible, is to put a patient in a long-acting bandage because it's less dressing changes at home. It's more comfortable for the patient. It allows for healing without having to expose it to air, which can make it more sensitive. So generally, our goal is a long-acting bandage. That in the emergency department is Meplex AG. It's a silver impregnated foam bandage that is meant to stay in place for 5 to 7 days. Although in the beginning, after a fresh burn, there's a lot of drainage that comes out of the open wound. So a lot of times we try and get that changed within the first 3 to 5 days, depending on how exudative the wound is. There is another type of long-acting bandage that we sometimes use on deeper partial thickness burns or even sometimes full thickness burns. Those burns usually have required a burn surgery consult. So will not have that readily available in the emergency department. That's something our burn nurse practitioners will bring downstairs if it's indicated. So you may see that. That's a bit of a stronger penetrating silver impregnated bandage. It gets applied with a silicone layer. It's a little more of a multi-step process and kind of requires a little bit more technique to it. So we use that in some cases. That's our goal, right? That's not feasible necessarily to like wrap up somebody's nose, right? It's not necessarily feasible or easy to put a big foam around a little kid's fingers. So what we use as other possible bandages is Zeroform, which has bismuth in it. And is an antibiotic gauze. If there's a burn to a small child's hand, our burn surgery team will put Zeroform on the hand and actually leave it in place because it's easier to wrap little fingers with that. Sometimes we use that on the face and the genitals. Sometimes we use bacitracin. Those all are often daily bandage changes. And then if there's a full thickness wound or a dirty wound, sometimes we're using Silvanine. So those are generally the bandages that we use. I'd say the majority of patients get Mepalex AG, but there are some other indications for other bandages in those at that first debridement.
So do any, like you said that the Mepalex AG is available in the emergency room. Is there anything that we need to order that gets ordered by from pharmacy that we have to wait to get delivered? Liz, do you know of like anything else? I know like bacitracin is readily available, right, in the emergency room, but other than that, like
Yeah.
Aquaphor and
Silvanine.
Yeah, Aquaphor and Silvadene have to be ordered and then verified by pharmacy. But the bacitracin tubes are in our Pyxis and can be verified and removed quickly. But if you
wonderful.
need Aquaphor, Aquaphor or Silvadene need to be ordered, as much ahead of time as you can.
I just thought about Vash cleanser. That's a special cleanser that we use especially for faces, which require at-home care that's twice a day. That's a special order? That's not in the Pyxis,
right? That's correct. That's a special order.
Do you guys use Vash in the emergency room, or is it mostly
No, we
just
usually use the
water,
wound cleanser like Ann said, or just soap and water.
Okay. But Vash definitely is available if needed.
Yes.
And Liz, do you want to talk about the special dressing, the way we do our Anne spoke about the hand dressing, and do you want to talk about the process that we use to actually dress the hand so that if we do have finger involvement, so that it promotes better healing without adhesions?
Yeah, absolutely. So this is really, a quality improvement initiative that actually Anne spearheaded. So, and correct me if there's anything I'm forgetting, but we recognize that with very young children, so less than 2, and again, that's a very common age for these types of injuries. It's really hard to get those wounds debrided on hands and to get them clean, and they tend to be pretty wet as well, and the child is obviously upset. It's upsetting for families too. So instead of getting teeny tiny pieces of foam to stick around these little fingers and then wrapped accordingly, using a dressing like Zeroform, it's actually going to stick a bit better. It's going to adhere a little bit better. The goal is to wrap each finger individually, with Zeroform also protecting the back of the hand or front of the hand if they're involved, and then to wrap everything together like a boxing glove, securing it with either a tube of fast dressing or sock or something like that. Again, there should be enough moisture in there that it won't dry to the skin, to the freshly healed skin or healing skin. But again, enough that the families don't have to deal with it at home, or it's not just, a terrible mess when the family comes to clinic.
Yeah, the hand is so hard because kids, they can't not use it, right? So to be able to dress it so that they're able to heal properly is so important. And
If
Dr.
you want, and you give me a second, I can share my screen and show you that process.
Yes, that'd be great.
Perfect.
Okay, so let me find it for you. Okay.
Yes.
Can you see the?
Yes.
There it is. All right. So this is our management of a hand burn consult, and this is for our surgical team who's generally doing this. We debride the burn first, and then we wrap each finger individually in Zeroform. So you can see that here. And then we wrap with cling, individually wrapping each finger. We generally wrap the thumb out and then wrap it almost like a mitten, right? So each finger is wrapped individually with Xeroform so that they don't adhere to each other, so that every part of the burn is covered. You only have to wrap the fingers that are affected. But if it's on the palm, the easiest thing, instead of trying to do a strip down the palmar surface of a finger, is just to wrap the entire finger, especially because once these are moist wounds, it's really difficult to kind of, things start sliding around a little bit. So we're just trying to get everything covered, wrapped like a mitten, and then we either put a sock or some sort of sleeve or glove over it. And then we ask that the family leaves that in place, or does their best to leave it in place. It can be tricky in this age group. And then follow up with us in burn clinic within about 3 to 5 days. We will triage it. So some patients will bring in after a day or two later, and some patients will wait the full kind of 3 or 4 days.
Yes, and then this is also in our
app.
trauma app, yeah. So
Yes.
that if you need any more references, you can go back under the burn, and then special consideration for him. And Dr. Isby, can you talk about a little bit on who you guys use to in the room when you guys do the debridement? Who is in there to help you guys hold and help with the process? And yeah.
Sure. So in the room, we usually have either the bedside nurse or a tech to help hold, and then at least one, usually two of us to help with the debridement, especially in younger kids. They're going to be moving and crying. Like I said, a key is talking to the parents ahead of time, telling them they're going to be crying, they're going to be moving, even with their pain as well controlled as we can get it. They're going to be mad that we're holding them down and scrubbing something with cold water. So preparing the family for that. I don't expect family members to assist in holding. Some families will ask that they want to kind of hug the child and talk to the child and be near them, and that's absolutely fine if they're offering or requesting to do that. But we should have enough staff in the room that the family can sit and talk or comfort the child without having to be involved in physically restraining the child while we're doing it. And then kind of as I'm talking through that process, directing, like you said, the people that are helping you hold and where to hold and how to hold as well. And trying to keep that extremity kind of restrained so that, or, if it's an extremity, keep it in one position so that we can get things wrapped, which can be tricky.
Thank you. And so I guess we're kind of like starting to look at as we discharge these patients. And you guys spoke about that. You guys will the patients will follow up in the clinic about 3 to 5 days. Where do the family do the families get get the extra materials they'll need in between the ER visit to the clinic visit, like the extra cling or whatever materials they may need? Liz, do you think you could speak on that?
It's pretty common practice to send families home with, either maybe a portion of the unused Mepil XHG that might have been placed on the wound, or a couple of extra wraps. We don't want to give them too much, because we do want to know if the wound is highly exudative. So if the child has soaked through, with a burn to the abdomen, if they've soaked through the gauze and the Tubifast shirt on top, then that's something we should know about, because it's evidence that the burn actually may be converting or becoming deeper. But in general, just a couple of extra supplies for that reinforcement for those few days until they get to clinic is something that is pretty standardly given to the families.
I've also seen families who change it like every few days, and then by the time they get to us, hopefully if it's healed, it's no problem. It hasn't been, but sometimes if it's a deeper injury, it's something that we would have actually wanted to evaluate with the first dressing change. And so, we've pushed off that evaluation to get it into a stronger bandage or a stronger treatment. So we want them to have enough that they're not stuck at home with no backup plan and kind of like in an extreme situation, but we also don't want them to have so much that they don't end up following up with us, because that can be problematic sometimes.
And do they know when when they will follow up with the clinic once they get discharged, or is that something that they will find out once they get discharged from the hospital and somebody will call them for that appointment, or will they need to follow up, like call the clinic for the appointment? How does that process work?
Yeah, so it's recommended that families So there's two ways that they can follow up in clinic. One is that they can call and make an appointment. The other thing is we receive an email to our burn team from the emergency department providers or our surgical providers when they see a burn patient, so that we can make sure that we get those kids into clinic on our end. So we will actually expedite getting kids into clinic. We also will triage patients. Sometimes patients need to be seen sooner than 3 days. And we have a full clinic, and they wouldn't actually be able to call and make an appointment because there's not an available clinic space. And if it's something that we really need to get urgently into clinic, we will find a way to get them into clinic. And so that's another reason why we really appreciate that the emergency department providers go through the extra step to notify us when they see a burn patient, because I know that's also another step of emailing us and getting the contact information. Because we have a limited number of clinic spots and we try and triage them as best as we can. If families happen to not hear from our call center within like a day or two, then we ask that they call to make a follow-up appointment, because we also don't want them to sit at home kind of waiting for a call and then it either slips through or the message doesn't get put through and then they don't get a call. So a little bit of both, but they should be provided with the contact information for our team, as well as the contact information to make an appointment when they leave the emergency department.
And Dr. Isby, do you know what is the discharge process? Like, what type of discharge instructions should the residents use once when the patient is ready to go home?
Yeah, so we have a custom discharge instruction packet that we made with the burn team, and it goes over all of the information they just discussed, as well as the email and the phone number for the burn clinic and how to get in touch in weekends and after hours if they have concerns. So our expectation is that the team is loading those instructions for each burn patient so that they are able to easily get in touch with the team if they need it. And then the resident or the nurse, if they've been in there and know all the steps, should go in the room and go over all the paperwork with the family. And usually, as we're doing the dressing, especially as we're doing the wrapping up portion, to talk to families, partially, obviously, to give them information and also to kind of keep going and keep their mind off what is going on. I usually talk to them and say, this dressing has silver in it. It's going to keep the skin safe. We're going to need you to come back in 3 to 5 days. And we go over it again. If their kid's screaming, it's obviously not the best time to listen, but trying to kind of reinforce to them multiple times, kind of leaving the dressing on, calling if things aren't going the way they expect, or if the kid is, having fevers, not eating or drinking. Those are all reasons we want them to come back or reach out to the burn team. So we try to kind of review those a few times with families, just because there's so much going on and they're usually distressed about what's happening. And so we want them to hear it a couple of times and then have that paper reference at home too.
Awesome. I'm sure the repetition definitely helps throughout the process. And Liz, what are some other resources that we can provide for these families that are out there with the in regards to like burn care and like what the process could look like throughout their treatment?
Yeah, so we have a number of videos that were produced. So the QR code to these videos is in the ER discharge instructions, as well as paper pamphlets that can also be given to the families. And these videos cover everything from, again, how to do dressing changes at home, if that's what's prescribed, what the burn care or the burn clinic experience is like. So that video includes things like, giving oxycodone 30 minutes ahead of the visit, bringing a comfort item for your child. It shows which elevators to take to go up to the clinic as well. So that's another one. We also cover the depths of burn injury, and then just, some psychosocial resources too. We have our psychologist in one of the videos really talking about, taking care of yourself if you're a parent of a child who has had this injury. So I think there's 13 videos total, I want to say, but again, we even have them on the Get Well network. So if the patient's admitted, those videos are ordered so the families can learn more about the surgical care environment, the operating room, et cetera.
Awesome. Thank you. And then and the oxy for the patient that gets discharged, when is that for? Who is that for? When do they take it?
Yeah, so we would like our patients to be able to take 1 dose of oxycodone prior to their first burn clinic appointment. And if they're able to get it, generally it's electronically prescribed, or they're given a prescription for it from the emergency department. When they leave the emergency department, they can then pick it up either at the Walgreens that is at Children's National. That's ideal because we know that they have liquid oxycodone for the younger patients at our Walgreens here. But if there's another pharmacy that we know that has that, then they could send it there as well. It helps with the first burn debridement because the first burn debridement and dressing change cleaning in clinic, because that generally is the most painful one after the emergency department. And we would like to give something more than Tylenol and Motrin. We do not have sedation available in clinic. So oxycodone is the strongest thing that we can give. It is something that expedites the patient's time in clinic and their throughput if they are able to take it beforehand, because we like to give oral medications about a half an hour before proceeding with the debridement. And if they take it before they come, and then they can wait the half an hour, and then they don't have to wait while they're sitting in clinic for their oxy to take effect.
Awesome, thank you. And that's usually prescribed with their discharge paperwork from the emergency room, correct?
Correct.
Awesome. And then Dr. Isby, you did say that there is a process that you guys follow on how you guys consult with the surgery. Do you guys have also, I guess, what is our process for admissions? Like, which of the burns do we usually admit?
Sure. So that's in consultation with the surgery team, since they would obviously be admitted to the surgical service. So it's in discussion with them. Any patient who is greater than 10% is almost, 100% going to be admitted, because they will need more close follow-up, as well as may need fluids and nutritional help. We have a burn is considered a trauma activation for any burn greater than or equal to 25%, and then a trauma attending activation for anything 40% or greater. So that's whether, if we get called from the field that they think that is the percentage of burn, then we will have our team meet kind of in the code room or the trauma burn. And then we consult trauma and burn surgery for anything greater than or equal to 5%, even if we feel it can be debrided by the ED team. And then, like I said, admission is in discussion with them, especially in the younger kids in that 5 to 9% range. Really, sometimes, they're a little tricky. They sometimes can be the ones that don't eat or drink as well, and may need IV fluids or NG feeds to help with healing. And then if for some reason is a concern for non-accidental trauma, then we would also plan for admission for further workup and kind of information collecting.
Awesome, thank you so much. And then I know a lot of times when residents get called down for these consults, these are like first-time residents that are dealing with pediatric patients and aren't the most familiar with burns. Liz, do you think you can talk about the different support or resources that are out there for them, who they can reach out to, and how and where they can get a little bit more information?
Definitely. A few years ago, we created a video about burn debridements in the emergency department. So that's certainly something that's good to review. It goes through a lot of what we've discussed here, types of dressings, exactly how to debride, which discharge instructions to use, how to get a patient to follow up. So I would certainly start with that video. And then, the pediatric emergency department attendings, I mean, they are the experts in pediatric care. So they are the resource that one needs in the room when performing this procedure. Again, they have that pediatric expertise. They can help talk to the family. They've seen lots of these. They can help guide pain management. Again, so many great things, so many great resources. So definitely your emergency department staff, also your bedside nurses, lots of great resources there. As I said, definitely review the video as well.
Awesome. Thank you guys so much. This was very knowledgeable and very helpful to just kind of go through the process of all of our burn patients that go through the ER. As we close up and like finish up, is there, I'd like you guys to share one, I guess, one like point that you think is the most important for you guys for regards to debridement and dressing, starting with Dr. Isby.
I
Like
think
one takeaway, I guess.
Yeah, I think what Liz was just saying is that we're all there to work on the same team. So feel free, you know, especially if you're new to debriding or new to the pediatric role, please have the attending, at least the resident in the room, help you help guide you through it. We are more than happy to help you assist in ordering, getting supplies ready, whatever the surgery team needs to help try to make things smooth and seamless. And then just ensuring that they have the proper follow-up paper and plan from the surgery team when they're down there so that they can get the care they need outpatient.
Awesome. What about you, Anne?
I'd like to say that there are a lot of resources, and sometimes it's hard to remember where they are and how to find them. But in our app, we have an entire burn section, and that speaks to, and that can be accessed by emergency department providers, surgery providers, nurses, etc. If you don't have access to the app, reach out to our team. But there's a whole burn section. And so it speaks to if it's this age and this percent TBSA, consider admission. If we're, you know, what percent is the trauma activation and what percent, you know, what it talks about what should go home with the patient if just for discharge. It talks about the pre-medication. It talks about the follow-up plan. So we really have a lot of information there. So that's a really good source. Also, the videos online are helpful for the families, so point them in that direction. But I think the videos online are actually helpful for us as well, right? Like there's burn debridement ones, there's ones about clinic. So if you have any questions or if there's anything you want to know, we have resources. If you can't find them, reach out to us. We're always happy to help. We want to facilitate the process of getting kids from the emergency department to burn clinic. We want to make sure the debridement goes well, and we want to make sure that people are comfortable with the care that they're providing, because we are all serving as the team that's taking care of burn patients.
Yeah, it's so important because like we said, that it's such a traumatic injury, and like the whole process can be traumatic, and to understand that we are here to make the trauma less, hopefully. Liz, what about you? One takeaway from this?
Yeah, I think it's important to recognize again what the actual burn clinic atmosphere is like. You know, it's exam rooms without monitors. Again, the only medications we can give are the oxycodone, or if the parents give the oxycodone, Tylenol, Motrin. So we're quite limited in terms of what we can give. The good medicine we can give in the emergency department, but again, we're really limited when we're up in the clinic. And then also, you know, we don't have a walk-in clinic. We don't. These visits require insurance authorization, so it usually takes a few days to get that established. So again, really setting that expectation with families who may, you know, again, be under the impression that the child needs to be seen, you know, tomorrow or next day, but really reassuring them that our team will review the child's case and really determine the best course for follow-up, the exact time frame. I also really wanted to, I thought Dr. Isby did a nice job explaining that taking the time to tell families exactly what's going to happen, including taking that picture, is very helpful too. So I'm going to use that in my own practice and explain to families that I'm not, you know, just quitting in the middle to get a quick picture, but I think that's really helpful just to say exactly step by step what this procedure is going to look like.
Awesome. Thank you guys so much. Thank you, Dr. Isby, for joining us for the BurnCast and providing your perspective from the emergency room. And thank you, Liz and Anne, for always joining us and providing us with your expertise. But we have hope that this will help the nurses as well as the residents going through the whole debridement and dressing process. Thank you.
Thank you.
Thanks.
Thanks.